الدكتور علاء اداني فرصه ان انا اقدم الاستاذه الدكتوره غاده السيد. ده مسك الختام بالنسبه للمؤتمر بشكل عام. الاستاذه غاده السيد استاذ القلب في جامعه القاهره، وهي من انشط الاعضاء حاليا في جمعيه الضغط، عملت تطور كبير جدا في موقع الجمعيه مع الدكتور عزة فراج، وايضا في المجله بتاعه الجمعيه. الدكتورة غادة هتكلمنا على موضوع واسع أوي شوية كده، اللي هو non pharmacological treatment of hypertension. ده طبعا من أول اللايف ستايل لغاية
بسم الله الرحمن الرحيم. Good afternoon, my professors and my colleagues. First of all, I would like to thank Professor Dr. فتحي مقلدي على الانترودكشن اللطيفة جدا دي. ميرسي جدا يا فندم. أحب أشكر الأستاذ دكتور ياسر عبد الهادي والأستاذ دكتور خالد خشاب على الدعوة الكريمة، وأساتذتي في جمعية الضغط، وعلى رأسهم الأستاذ دكتور محسن إبراهيم. الليكتشر دي ان شاء الله هتبقى على النون فارماكولوجيكال انترفنشن هايبرتنشن، وانا التاسك بتاعتي بقت اسهل بكتير بعد كل المحاضرات اللي فاتت. الاجنده ممكن بس البرزنتيشن. اوكي ثانك يو. الاجنده اللي احنا هنتكلم عليها، هنتكلم على salt restriction, weight reduction, cessation of smoking, regular exercise and adopting a healthy diet. First, let's talk about restriction of sodium intake. Worldwide, the daily salt intake consumption is almost double the standard or recommended daily salt intake. In Egypt, of course, we have a high salt intake with an average sodium of 2.5 gram per day. And here we should differentiate between sodium and salt. Salt is a chemical compound consists of sodium and chloride. Sodium represents 40% and chloride 60%, and the sodium is the molecule responsible for elevation of blood pressure. Now, how can sodium cause hypertension and the other vascular phenomena? First of all, salt can increase blood pressure, causing high blood pressure through different mechanisms, including water retention, peripheral vasoconstriction, endothelial dysfunction, vascular stiffness, and modulation of autonomic activity. Not only hypertension, but sodium also causes many other cardiovascular and vascular abnormalities, including increasing the risk of heart failure, increasing the risk of cardiovascular diseases, kidney stones, damage to the kidney, weakening of bones, and gaining weight, because sodium, of course, added to food increase the palatability of food and thus increasing the food intake. As my dear professor said before, we have not only the salt in the cooked food, but also we have sodium in other food components, including the sodium used for food preservation, the monosodium glutamate, the sodium bicarbonate, which is used for baked food, and the sodium benzoate. And you can see here any salted or canned food contains a lot of sodium, and the other things like the bread, the pasta, the sauces, the rice, the nuts, all of these contain high salt content. Not only the salt in the food, but also you can take sodium in many other forms in your daily food consumption. And it was shown that reduction of salt by 1.75 gram per day, which is equivalent to 4.4 gram salt reduction, is capable of reduction of blood pressure, systolic blood pressure in the population by 4.2, and in hypertensive patients by 5.4, and the diastolic by 2.1 and 2.8. Not only the reduction of blood pressure is achieved by reduction of salt intake, but also reduction of overall cardiovascular risk by about 18 to 26%. That is why the different institutions, including the WHO, the European Society of Hypertension, the European Society of Cardiology, and the American College of Cardiology, recommended to reduce salt intake to less than 2 gram, sodium intake to less than 2 gram, which is equivalent to sodium chloride, which is table salt, by less than 5, and the American 2.3 and 5.75. Now, so it's beneficial to reduce salt intake. Can we reduce the sodium intake less than 2 gram per day? Actually, the relationship between salt and hypertension or overall cardiovascular risk is a J-shaped relationship. So very high salt intake and very low salt intake are associated with increased cardiovascular risk and the cardiovascular mortality, and actually low sodium diet can stimulate the RAS system and thus can lead to salt and water retention and reversal of the action of lower salt. And the most recent European guidelines recommend that we substitute part of the daily salt intake by potassium salt, sodium instead of sodium salt by potassium salt. So we are going to substitute 25% of sodium chloride by potassium chloride, preferably in the potassium-rich food like the lentils, the beans, the tomatoes, the bananas, the raisins, and the unsalted nuts. But take care in moderate and advanced chronic kidney disease, potassium salt may be harmful, and also in patients who are taking potassium-sparing diuretics and in patients taking RAS-blocking agents, because the potassium may be elevated to serious levels. Now, the second mode of intervention is healthy diet. In the guidelines, they describe two forms of diet, and the two are quite similar in their components, which are the DASH diet, an abbreviation of dietary approach to stop hypertension, and the Mediterranean diet. The essence of these diets is to reduce the fat consumption, especially the saturated fats, and the reduce red meat, and reduce overall caloric intake. And focus on whole grains food, fruits and vegetables, and the unsaturated fats. Also in the guidelines, they recommend against liberal use of sugar and sweetened beverages like the sodas and the sugar-sweetened juices, because the sugar as well as the salt, of course, you know, the salt and sugar are called the white killers. They both increase the cardiovascular risk. In this study, they randomized patients to 3 forms of food intervention. The controlled diet, in which they allowed patients to consume the average amount of fat plus low vegetables and fruits. And the other group of patients allowed to consume fruits and vegetable-rich diet. And the third group of patients are allowed to consume the DASH diet, which consists of increase fresh vegetables and fruits, low fat dairy products, and reduce the saturated and the total fat. As you can see here in the graph, that the highest reduction of systolic and diastolic blood pressure was achieved by the DASH diet, that the systolic blood pressure was reduced by about 11.4 millimeter mercury, and the diastolic blood pressure was reduced by about 5.5 millimeter mercury. Moving to physical exercise. In this meta-analysis, which included 34 trials recruiting about 1,787 participants, they found that each 30 minutes per week aerobic exercise was able to reduce the systolic and diastolic blood pressure in addition to the heart rate. And this effect was even augmented in hypertensive patients, that this level of physical exercise, only 30 minutes per week physical exercise, was able to reduce the systolic blood pressure by 7.2 and the diastolic blood pressure by 5.6 millimeter mercury. What level of exercise are allowed for hypertensive patients? We have many forms of exercise. We have aerobic exercise in the open air and other exercises. Resistance exercise. The resistance exercise is the exercise that the muscle exerts against a weight or a force. In the guidelines, they recommend that moderate intensity exercise, 30 or more minutes per day for 5 to 7 days per week, for a total of 150 minutes per week at least of moderate exercise. What kind of moderate exercise? Moderate exercise is represented by walking, cycling, swimming, vacuuming. This is a moderate exercise. Or alternatively, 75 minutes per week, vigorous exercise over 3 days, and the cycle to be repeated for the next week. What kind of exercise is considered vigorous exercise? Like playing football, dancing, swimming. And they said that this is class 1A indication in the recent guidelines. And they said that you should complement this aerobic exercise by resistance exercise, either dynamic resistance exercise or by static resistance exercise. In dynamic resistance exercise, this is a resistance exercise with motion, while in the static resistance exercise, it's a resistance exercise with stasis. Now moving to weight reduction, of course, it's well known that obesity can cause hypertension, not only hypertension, but other cardiovascular adverse effects, and it's a risk factor for cardiovascular morbidity and mortality through different mechanisms, and these mechanisms include the biochemical alterations, the physiological alterations, the anatomical alterations, and the genetic background. And it was shown here in this study that it's for an average loss of 4 kilograms of weight over a period of 3 months, it was capable of reduction of systolic blood pressure by about 10 millimeter mercury and reduction of diastolic blood pressure by about 5.6 millimeter mercury. So in the most recent guidelines, they recommend to reduce weight, how much reduction of weight to reach a body mass index of a healthy level. What's the healthy level? That's a body mass index between 20 and 25 kilogram per square meter. And also to keep the waist circumference in order to avoid the visceral obesity between less than 80 in women and less than 94 in men, centimeters in men. How can we reduce weight? We can reduce weight through 2 mechanisms: adoption of a healthy diet and regular physical exercise. Of course, if these measures fail, you can adopt pharmacotherapy. Pharmacotherapy is well known to reduce weight, but the role of pharmacotherapy in reduction of blood pressure is still questionable, needs more evidence. And in morbidly obese patients, patients with comorbidities, and patients in whom other interventions fail, we may use bariatric surgery to allow for weight reduction and reduction of overall cardiovascular morbidity and mortality. Now moving to smoking cessation, of course we all know that the cigarettes containing many toxins, about 20 compounds of toxins. One of these toxins is the nicotine, and the nicotine is the constituent or the molecule responsible for elevation of blood pressure because it causes sympathetic stimulation and it causes elevation of heart rate and the blood pressure within 20 minutes after smoking cigarettes. This is called acute hypertensive effect. Other toxins present in the cigarettes like carbon monoxide, oxidant gases, other toxic compounds may lead to vascular abnormalities, oxidative stress, and leads to development of atherosclerosis, which also causes vascular stiffness and may predispose to hypertension as well. This is the effect of smokers when they quit smoking. Actually, the heart rate and the blood pressure returns back to baseline levels only after 20 minutes of quitting smoking. But the long-term effect on quitting smoking are mainly seen on the coronary artery disease and the stroke and the vascular abnormalities. After 1 year of quitting smoking, the rate of coronary artery disease drops by 50%, but it takes 15 years for the incidence of coronary artery disease to reduce to baseline or non-smokers level after quitting smoking. So it takes a lot of time for the body to get rid of the cigarette toxins. Now, when describing or prescribing a cessation of smoking to a smoker, especially a chronic heavy cigarette smoker, you should approach the patient through this 5 A's. First, you should ask the patient about how many cigarettes you smoke per day, for how long duration you have been smoking cigarettes, and then you should advise the patient about the harmful effect of cigarettes and how can cigarette smoking affect their vascular health. And then you should assess the willingness of the patient to stop smoking, because patient's compliance and patient's willingness to stop smoking is a very important step in the pathway of cessation of smoking. Then you should assess the patient to send the patient to smoking cessation program, to arrange for group therapy to allow the patient to stop smoking, and then to arrange for follow-up in order to stress on the harmful effect of cigarettes and to stress on the importance of stopping smoking. The strategy for smoking cessation is first to send the patient to a specialist to engage the patient into smoking cessation program, and then to recommend behavioral therapy, because usually smokers, they explain their cigarette smoking by the environmental factors, the daily stresses. So this patient should be subjected to behavioral therapy, and If not, pharmacotherapy is always there, nicotine replacement therapy, and 5 forms are being accepted or have been approved by the FDA, which are the patches, the lozenge, the gum, the inhalers, and the nasal spray. And we have 2 other drugs which act on nicotine receptors, bupropion, which acts as a blocker of nicotine receptor, and the varenicline, which acts as a partial agonist or competitive inhibitor of nicotine receptor. And of course, they found that the combination between behavioral therapy and pharmacotherapy was the most effective in the cessation of smoking. Now, the emergence of e-cigarettes, first of all, they were discovered or they were described as being a method of cessation of smoking. But the liquid they use in the e-cigarettes now contains nicotine, and thus the e-cigarettes have the same adverse spectrum as the cigarette smoking. The nicotine causes increase in the heart rate, tachycardia, and the hypertension, and the other toxins present in this liquid also causes cardiovascular and vascular abnormalities. So e-cigarettes are not that safe anymore. Last but not least is the stress management. The stressful situation is very important environment in developing hypertension, and in the latest European Society of Hypertension guidelines, they recommend to reduce stress via different mechanisms. Of these are the meditation, the breathing control, and there are certain devices which allow patients to regulate their breathing to allow for stress management. So to conclude, lifestyle measures or non-pharmacological measurements for control of blood pressure are indicated not only for hypertensive patients, but also for patients with elevated blood pressures and for patients with non-elevated blood pressure even. And there are different mechanisms through salt restriction, weight reduction, smoking cessation, healthy diet, physical exercise, and stress management. Thank you.
شكرا دكتورة غادة على هذا الموضوع البالغ الأهمية، وزي ما سيادتك أشرت كده إن اللايف ستايل موديفيكيشن ده more effective than drug treatment في reduction of the blood pressure. إن إحنا بيواجهنا مشكلتين في الحكاية دي. البيشنت is not compliant to lifestyle modification، لأن دي حاجة أصلها يعني داخلة في psychological make up بتاع العيان والenvironmental وليه عوامل متعددة. And the inertia of the doctors to sit with the patient, to talk to him about the importance of lifestyle modification. 2 مشكلتين كبار جدا في حكاية lifestyle modification. شكرا جزيلا.